the rationale of our study was to compare the proton therapy to photon therapy in stage 3 non-small cell lung cancer treated with concurrent chemotherapy with a focus on hematological toxicity. Since proton therapy has peculiar physics properties that allow them to better focus the radiation at the target while sparing organ at risk. And since concurrent chemotherapy is a toxic treatment, we would like to understand whether protons might spare toxicities, particularly hematological toxicity. And the primary endpoint of our study was the incidence of grade 3 or worse lymphopenia during concurrent chemotherapy. We enrolled 169 patients, 35 treated with protons and 134 treated with photons. The two treatment arms were well balanced regarding disease stage, gender, histological subtype of the tumor, age, and also gross tumor volume. What we found was that proton therapy could indeed spare hematological toxicity, since proton-treated patients experienced significantly lower incidence of lymphopenia grade 3 or worse during treatment. 46% in the proton arm compared to 75% in the photon arm. So the primary endpoint of the study was met. And the protons also show to spare the incidence of severe anemia, and also the patients treated with protons presented with better performance status 21 days after the end of concurrent chemotherapy. On top of that, what we did to also mechanistically explain our results was to analyze the DVH parameters. And we see that lymphopenia was correlated with the bone marrow doses, so the radiation dose delivered to the bone marrow, particularly V4, V5, V10, and V20. And afterwards, we also compared the protons versus photons treatment plans. And we showed that protons spare the bone marrow. So less lymphopenia in the proton treatment arms was correlated with less bone marrow radiation dose delivered with protons. So that explained our results. The future direction would be, just understand if this reduced rate of lymphopenia would translate in some clinical meaningful benefit for the patients, like better survival, better response to immune therapy, which is the adjuvant treatment after concurrent chemotherapy. And of course, if so, then that will lead to some treatment optimization, also taking the bone marrow into account.